So our speaker for today is Monika Kastner, and the title is Effectiveness Aging Tools Addressing Multiple Hybrid and Chronic Diseases Affecting Older Adults. I just want to remind everybody that the process is going to use questions, because we do have some people that are attending via the webinar as well. So questions will be answered at the end of the presentation. Please do put questions for that. We'll go through each of the online sections and then we'll take questions. People who are online, please send your questions through the WebEx interface, and Dale, who is here, will read the questions on your behalf. I'd also like to remind people who are online the microphones on mute. So it's my pleasure to welcome our speaker today. Monika is a scientist here with the Knowledge Translation Program at the Knowledge Institute. She's also a professor in the Division of Epidemiology at the Downland School of Public Health at the University of Toronto. She has a PhD in Health and Health Services Research Program and is currently developing the Aging Well Initiative, which is funded both by the Greater Ministry of Health and by JHR, which involves the development of aging tools that can integrate care of multiple hybrid and chronic diseases.
Thanks everyone for attending this afternoon, and also to those of you that are attending online. So today we'll be discussing the development and the results of
Monika, it's Dawn Stacy in Ottawa.
Hi.
We're having a lot of problems hearing you.
Okay, just 1 second, and we're going to look into it.
You're on.
Dawn, can you hear us better?
That's much better.
Okay, hi everybody. I hope you can hear us now. So going to begin. So thanks everyone for joining us this afternoon, and for those who are joining us online.
Monika, can you get closer to the microphone? It's Dawn again.
Here's Dale.
Sorry,
I hear you really well, but there seems to be distance.
Okay. Is this better, Dawn?
Yeah, that's much better.
Okay, wonderful. So just to give you a little bit of a background on this project, it really has been born out of the problem that more than half of older adults have 2 or more chronic conditions such as diabetes, COPD, and depression. And this population has a greater healthcare needs, and they experience more hospitalizations and adverse events, yet only 55% of them receive appropriate care. So in response to this, there has been different chronic disease management and knowledge translation strategies that have been created. The problem is that most are not developed for older adults. They're not created for sustained use, and they're primarily focused on a single disease. So as a result of this, the care of older adults remained suboptimal. So the objectives of our work was to conduct a systematic review to identify effective chronic disease management knowledge translation interventions or tools that integrate 2 or more hybrid and chronic diseases affecting older adults. And our secondary objective was to determine which of these components of these interventions actually optimize their impact. Another objective is to conduct a realist review alongside the systematic review to determine the mechanisms underpinning these interventions. But this work is not being presented today because it's beyond the scope of our systematic review, but it's being conducted right now. So our protocol has been published last year, and our systematic review has been registered with Prospero, and we applied their PRISMA criteria for reporting the systematic review. Our search strategy was developed by an experienced information specialist, and it was validated using the PRESS checklist. We considered all these different databases in any language from 1990 to January 2015. And we put this restriction on it because a lot of the multimorbidity literature did not exist prior to 1990. Other sources we included were the great literature, and we also scanned the reference list of included studies. We also applied a validated age-specific search filter to help focus the studies on the older population. So our eligibility criteria then included this population, but the patients had to have 2 or more high-burden chronic conditions, and these were identified by several of these organizations. And we also included the reported top 11 diseases as identified by these organizations. So we included multi-chronic disease management knowledge translation interventions or tools, and we defined these as interventions that facilitate the ongoing proactive and preventive support for optimal disease management, and those that facilitate the uptake of knowledge about these chronic diseases. The interventions had to be developed for or applied to an older adult population with 2 or more chronic conditions. And the interventions had to be complex, so it could have multiple components, multiple targets, and they could include any quality improvement elements, such as those that are outlined by the Cochrane-EPOC taxonomy. Our comparator could be any other chronic disease management strategy or any control or usual care strategy. For our primary outcomes, we considered any outcome that looked at improving disease-specific chronic disease management as reported by the primary studies such as glycemic control and diabetes care. And because we anticipated a really wide range of outcomes, this was really what we were looking for, according to the identification of these impact outcomes per intervention. For secondary outcomes, we were interested in quality of life, health service utilization, and cost. And we included any study design except for case control studies, retrospective cohort studies, and any opinion-driven reports such as editorial commentaries and narrative reviews. Our study selection involved a calibration exercise initially with all the reviewers to ensure reliability of screening. So the reviewer pairs independently applied the eligibility criteria on a random sample of citations, and this process was repeated until we reached at least 80% raw agreement. The same procedure was used for selecting potential of relevant full articles, and disagreements were resolved through consensus or group discussions at all levels. Our data extraction process involved developing a standard and standardizing a data extraction form to collect information on study, population, and intervention characteristics, and to assess risk of bias and quality assessment using other quality assessment tools, depending on the study design. So, for example, for randomized controlled trials, we used risk of bias. So, as I mentioned before, we expected a really wide range of chronic disease outcomes, given that we searched specifically for 11 chronic diseases. So we ended up using the Cochrane Consumer and Communication Group taxonomy of outcome categories, and these are the ones listed that were relevant to the outcomes that we've identified. So data synthesis involved a descriptive summary according to study, population, and intervention characteristics, the assessment of the effects of these interventions across the different outcomes, and again, given the anticipated complexity of the intervention evaluated across studies, we expected a very high level of heterogeneity, and we are currently exploring some options around whether we can pool certain studies, and if we will do that, we'll use the random effects model to account for between trial variations. We're also planning to perform some subgroup analyses to assess outcomes by different disease cluster and different interventions with similar components or similar combinations of components. So our decision to pool studies are being based on the exploration of statistical, methodological, and clinical heterogeneity. So we're looking at the I-squared statistic for our statistical heterogeneity. In terms of clinical heterogeneity, we're examining outcomes according to population characteristics, so age, sex, and disease cluster. The examination of intervention components to determine those with similar or same components or combinations. So there's an example. education plus reminder plus facilitated relay. And we're also looking at methodological heterogeneity, and these are the risk of bias factors and other factors such as study duration and loss to follow-up. One of the interesting parts of our work was really to identify the components that may be contributing to the impact of these interventions. So we went through a systematic process to deconstruct the interventions to really identify the core ingredients. So the objective of this was really to determine which intervention component or combination of components contribute to the impact of interventions, and also to use this information to identify studies that may be potentially pooled. So the process involved taking the interventions and deconstructing it by reviewer pairs who independently coded these components using content analysis. So the coding of elements involved creating a codebook which was iteratively developed with the use of each additional intervention that was coded. And the initial codes were guided by the established quality improvement criteria according to EPOC and some other work. And the final decisions on code was developed also iteratively through group discussions. So just to give you an idea of what this process was all about, this is one study where we have a description. This is part of our data abstraction form. And so the reviewer pairs would then read through this intervention description and identify unique elements. So for example, the shaded areas represent the different sections that could be identified in this particular example. So we then took those different elements and we put them on their own, just like this on this data form. And then we further deconstructed this according to assigning a particular code. So in this case, it was case management. We also recorded by whom this particular element was delivered and to whom. So in this case, it was a social worker, care manager that was delivering case management to a patient, the setting that this happened, and the format. And then finally, we also categorized the intervention element according to belonging to those domains of the EPOC intervention category. So we did this with all of the different intervention elements, which then allowed us to create this configuration that represents the intervention in its elements. So this particular intervention that was called the personalized intervention for depressed patients with COPD can be represented as a case management plus education plus facilitated relay strategy. So going to the results now, this study flow diagram shows our flow of study selection. So we initially identified over 56,000 citations, and 6 reviewer pairs screened 46,000 titles and abstracts, which were then further refined to 1,700 full-text articles, which were screened by 4 reviewer pairs. So as you can see, this is a fairly exhaustive process. And we've identified 20 studies and plus 2 companion reports, which met the eligibility criteria. So I just wanted to give your attention to the reason that we had such a high yield across the studies is because we were extremely over-inclusive. It was very difficult for us to identify studies that actually applied those multimorbidities in their interventions. So we were over-inclusive on purpose, but this also put a lot of burden on our screening. In terms of our study characteristics, we identified 20 studies and 2 companion reports. This represented 9 randomized controlled trials and 5 cluster randomized trials, 1 uncontrolled trial, 3 mixed method studies, and 2 qualitative studies. They were conducted between 2002 and 2015 in the US, Australia, and Europe, and we did not find any studies that were conducted in Canada. The follow-up was reported in 15 studies, and this ranged between 2 to 52 weeks, a mean of about 26 weeks. The studies represented almost 12,000 older adults. Their mean age was 67 years, and a little bit more than half were women. They were targeted to older adults with different combinations of disease clusters. So 60% of all disease clusters included at least diabetes, which is not surprising. And this is the spread of other chronic diseases amongst the clusters. So we had 7 studies that include at least depression, 7 studies that included at least COPD, and so on. So the spread was actually very similar to what we're finding in prevalence studies in the literature. So among the different disease clusters, there was only one triad that we found, which included diabetes plus COPD plus congestive heart failure. The remainder were all dyads. So this is the breakdown of the disease dyad combination. So 26% of them included diabetes plus CVD, and 16% diabetes plus depression, and so on. So again, there was quite a spread across the different studies in terms of the dyad combinations. In terms of the interventions, there's a broad description of interventions, the way the studies themselves identified the studies. So 8 studies identified their studies as collaborative care. 5 were self-management with telecare or telemonitoring, and 3 were self-management without. There were 2 computer-based interventions and 2 cognitive behavioral. However, when we deconstructed the interventions, we actually revealed 9 unique components, and this is the breakdown of that. And the majority of studies included at least education as a component in the intervention configurations. So as you can imagine, you can slice and dice this data in many, many different ways, and which is exactly what we did to try and figure out if there's any patterns and what would be the most meaningful in terms of informing clinical practice and decision-making. This table represents the breakdown of interventions by the number of components or the complexity of the intervention by the type of intervention that it was described in the study, the intervention component combination, and the disease cluster that it represented. So we have the majority were 2-component interventions. Here we have identified some patterns there. As I go through this, I'm not going to describe them any further than that, but just to show you that we've gone through a really exhaustive sort of system to try and figure out what the patterns are. In terms of our risk of bias result, this is our Cochrane risk of bias diagram. So we found that 10 studies had low risk of bias for random sequence generation, and 13 studies had low risk of bias for all of the 3 outcome data factors. There was also a large proportion of the studies that were unclear for risk of bias, blinding, and there were 3 studies that had high risk of bias for blinding participants and personnel. We're currently working on the risk of the quality assessment of our qualitative studies. They appear to be fairly high quality, and we're looking at the mixed methods in the uncontrolled study right now as well. So as I said, there's many different ways of representing this data. So what we decided to do as a way of making this as informative as possible for clinicians and decision makers is to describe the results across the primary and secondary outcomes in terms of that categorization by the Cochrane Consumer and Communication Group. And this seemed to make the most sense in terms of organizing all the different outcomes that we had. So now I'm going to describe each one of these categories. So in terms of treatment outcomes, we had 13 studies that reported on treatment outcomes, depression being one of the largest categories of outcomes that they reported on. 8 out of the 10 studies that looked at depression showed significant reductions in depressive symptoms or depression severity at follow-up. In terms of the hemoglobin A1C, one study found significant reductions using an effect, and one study found a small effect, and 2 studies found no difference between groups. In terms of pain, both studies found significant reduction in pain intensity or having less interference with daily activities due to pain. There were 2 studies that looked at mortality, and neither of these groups differed between groups. There was also 3 studies that looked at antidepressant use or change in antidepressant use, and all of these studies found significant impact. So looking at that a little bit more carefully, I want to show you in terms of the breakdown of these depression outcomes, how this translates in terms of similar interventions. So this table shows, for example, all the different disease combinations that these studies shared. So there were 5 studies that shared at least education plus self-management as part of their intervention. And you can also see the breakdown of the disease clusters for these particular studies. And 4 out of these 5 studies showed significant impact, and then so on with the other combinations: education plus case management, education plus care pathways, education plus teams, care pathways plus teams, and then there was a 3-component combination that was directed to depression and diabetes, and another 3-component combination that was directed to all those different disease clusters. In terms of other treatment outcomes, so as I mentioned before, we only have in these tables representing the significant outcomes. We were trying to figure out what may be some patterns that may be responsible for those impacts. So for this particular set, we had 2 studies that actually did include this 3-component combination for pain, and it was directed at depression plus osteoarthritis or arthritis. And we also found that care pathways plus education may be responsible for the significant impact of antidepressant use. For the health status and well-being outcomes, there were 7 studies that looked at that. In terms of psychosocial outcomes, there was a study that found significant improvement in overall quality of life. Another study for health and well-being found no difference between groups. 2 studies investigating general health status. One was significant while the other was not. And another study found no improvement in patient satisfaction. So that was the breakdown for that particular group. For physical health, a study investigating the physical health component of quality of life found no difference. 2 studies investigating functional status. One was significant, although they did not provide some the p-values or other data, whereas the other study did not was not significant. In terms of health-related functional impairment, we did find one study that was significant. In terms of psychological health, a study investigated diabetes-related emotional stress and found significant reduction in the intervention group compared to control. And another study found significant improvements for cognitive status, while another study investigating the mental health component of the quality of life measure did not. So it is all over the place. And again, our table here that shows all the significant results, we were able to identify disease management plus teams that may be responsible for significant improvements on overall functioning or health-related functional impairment, while education was the common element amongst the psychological health outcomes to reduce diabetes-related emotional stress or improvement in cognitive status. So in terms of health behavior outcomes, we identified 6 studies. The first set of these had to do with medication adherence, and one study showed that adherence to adequate antidepressant medications contributed to the advantage of the intervention for reducing depressive symptoms. Another study showed no difference between groups for adherence to medication, and in that particular study they did not specify what type of medication they were looking at. Health-enhancing lifestyle and behavior, there were 3 studies that looked at physical activity, which we were very interested in. One study found a significant effect of exercise on reducing dyspnea-related disability, and this was a study with patients with diabetes and cardiovascular disease. Another study found this significantly more people exercised 30 minutes per day in the intervention group compared with control. And one study found significantly increased physical activity for the intention-perceived behavioral control and subjective norm in patients who received the intervention, but this was only significant in the short term, so 1 week. So by the time they did the 6-week follow-up, it was no longer significant. So again, looking at these outcomes across our disease cluster combinations, It appears that education plus self-management may be responsible for some of the positive impacts of physical activity, and education may be responsible for the other outcomes. Health service delivery was another group of outcomes that we looked at. In particular, we found 2 studies that looked at hospitalizations and length of stay. One study reduced at least one all-cause hospitalization admissions, but not all-cause hospitalizations or cause-specific hospitalizations or length of stay. One study found no difference between groups for rehospitalization, but a significant decreased time to rehospitalization in the intervention group compared with controls. In terms of service utilization of EDUs or urgent visits, there were 2 studies, and neither of these studies showed any significant impact. In terms of mental health service use, there was one study that looked at that, and they found that significantly more intervention patients used mental health services or psychotherapy than control patients. In terms of health economic outcomes, there was only one study that looked at costs, and there was no difference between groups for total outpatient costs, and there was very little data provided around this. So again, looking at across these combinations, it appears that education and telemonitoring may be responsible for this group that had congestive heart failure and COPD or diabetes. And skills acquisition, there was one study that looked at depression self-efficacy, and this study found some impact on the patients having more confidence in managing depression than those in the control group. And this particular intervention was targeted to patients for depression and osteoarthritis, and it was a 4-component intervention. There was 2 studies that looked at self-management and self-efficacy, and they found no difference between groups for self-efficacy. And also one study looking at medication self-efficacy also did not find a difference. And lastly, our knowledge and understanding category, there were 2 studies that looked at patient knowledge and acquisition, where they found a significant increase in medication knowledge in the group that received an intervention with telemonitoring compared to the intervention that received telephone alone. Another study found that the intervention group had increased diabetes knowledge compared with control. And there were 2 studies that looked at provider-level knowledge and skills. And in one of them, there were more patients in the intervention group who were referred to an exercise program than control, and significantly more attended a mental health worker meeting. And then there was one study that looked at deficiencies in cardiovascular disease and diabetes management, and in addressing the management issues. And so they found that the intervention patients had more primary care physicians address these problems than those in the control group. So again, looking across these particular interventions, education seems to be the commonality. And the diseases that this was targeted was diabetes and diabetes plus congestive heart failure or cardiovascular disease. So that's a lot of data. So how do we organize this data, and how do we interpret this data? So we started to look at some preliminary conclusions. As I said, we're going to use some of these organizations as a way of allowing us to potentially pool certain studies in a meta-analysis. But at this point, what can we conclude from this? So we know that if anything, that any of the interventions that have at least education as a component can reduce depressive symptoms or depression severity, and it can increase physical activity and antidepressant use in older adults with these combinations of diseases. When you add self-management to this, there are some studies that have reduced depressive symptoms or depression severity in those combinations of diseases, and it can also increase physical activity in those with diabetes and COPD. Education plus care pathways can reduce depressive symptoms or depression severity in those combinations, and it can also increase antidepressant use. When we consider combinations with care pathways, this also has some impact on reducing depressive symptoms and more confidence in managing depression in older adults with depression plus COPD or osteoarthritis or diabetes with CVD or depression. Care path or case management plus education can reduce depressive symptoms or depression severity in those combinations. And the three components, case management plus education plus self-management, can reduce depressive symptoms or depression severity in older adults with those two different types of combination of diseases. When we look at any combination that includes teams, it also can reduce depression severity in those with depression and diabetes or dementia, osteoarthritis and arthritis. The three component interventions can reduce depressive symptoms for depression and dementia, and another one can reduce pain and intensity in those with depression and plus osteoarthritis or arthritis, just by having either case care pathways or case management. So again, this is the last set of groupings that can also specify the different reductions in depressive symptoms for different types of disease combinations. So we further summarize this a little bit more, and it appears that coordination of care approaches, which include different combinations of case management, team, care pathways, plus an implementation strategy involving education, appears to reduce depressive symptoms in older adults with diabetes, plus depression or CVD or osteoarthritis. Coordination of care approaches involving the combination of case management, disease management, and team reduce pain intensity in people with depression plus osteoarthritis or arthritis. The combination of case management, education, and self-management can reduce depressive symptoms and increase the confidence in managing depression in older adults with depression and osteoarthritis. Education plus self-management reduce depressive symptoms and increase physical activity in older adults with diabetes and CVD. And education and care pathways reduce depressive symptoms and increase antidepressant use in older adults with diabetes plus depression or CVD. So we still have a bit of work to do to tease out some more of these results. So I just wanted to mention a couple of limitations that I just wanted to acknowledge. So as I mentioned before, our systematic review yield imposed a very high screening burden to begin with. And so there's several reasons why we think this happened. So we know that multimorbidity is not very well indexed in the literature. So what we ended up doing is developing separate search strategies for each of the 11 high-burden chronic diseases, which was actually nested within the search strategy. So this obviously inflated our yield a little bit more, but we had to do that in order to make sure that we capture everything. Identifying whether the intervention was applied to populations with 2 or more chronic diseases was very difficult at both levels of screening. And so we have to be over-inclusive in our selection to make sure that we were able to capture those, and we had to do that in full-text screening. Another potential limitation to our work is that other people may interpret our findings very differently, particularly in terms of the way that we've dissected our interventions. So, but in response to that, our approach to deconstructing the intervention was very highly systematic, and it was performed in duplicate to make sure that we had common understanding. And our interpretations were also guided by the EPOC criteria. And so with our work of the realist review, we're also going to identify the context mechanism and outcome configurations that come out of all of these studies and more, and that will allow us to actually explain further our findings. In terms of implications and next steps, so the strength of our study is that we have contributed to the current limited knowledge of chronic disease management KT interventions, particularly those that integrate the care of 2 or more chronic diseases affecting older adults. And we did that for the top, actually it's 11 high-grade chronic conditions. And we deeply examined a variety of interventions and outcomes which provides a more in-depth understanding of multiple chronic disease management in this particular population. I think that another really important finding is that we really see large gaps in the evidence, especially given that all the literature that we searched, we found relatively few interventions that actually looked at interventions that include or are applied to or are developed for multiple chronic conditions. So our next steps are to complete the remainder of the analysis plan, our subgroup analyses, and our potential for doing a meta-analysis. And again, as I mentioned, the realist review alongside this systematic review to give us a more in-depth understanding of the mechanisms behind these interventions. And then the relevant findings from both this work are then going to be used to develop, to contribute to the development of a multi-chronic disease tool that is currently underway. Finally, I just wanted to acknowledge the large number of co-investigators, particularly our core team, who have been tremendous throughout this process and without whom this project would not have gone to where it has. So I just wanted to thank everybody on this list for their contributions. And now I'm happy to take any questions that you may have.
I think we're going on to the web first. Do you have a question? Oh, okay, so Halifax?
Hi, thank you for the presentation. We do have a question.
Sorry. Thanks, Monica, for the presentation. My name is Logan Lawrence. I'm a PhD student here. I have 2 questions for you. One of them is from an implementation science perspective, what's your confidence like that the studies that you group together in terms of similar program elements, like what you label disease management or education, are actually similar in terms of how they were delivered, so like intensity, frequency, those kinds of characteristics? And the second question is, did you look at null findings, so studies that they anticipated to reduce some other outcomes or improve some of their outcomes, like that they didn't find those conclusions?
So to answer your first question, in terms of the, we tried to develop a code book to identify and define all the different elements, and then we tried to apply that to our studies. Unfortunately, one of the issues that we came across is that the studies overall were very poorly reported. So there are some things that did come down to judgment. And so to answer your question, that may have impacted or there could be some potential for misclassification as a result of that. Also, in terms of your question about looking at some other factors in terms of how the intervention was delivered, we are looking at some of that in more detail for our realist review, and we're going to try and match that up with some of the findings that we've had. Sorry, I'm not sure if I answered both your questions.
So my second question was more around, like, if you looked at some of the findings that the original study authors were hoping to find but didn't actually. So, for example, if they thought that their intervention would improve, you know, attitudes around a given condition, but they didn't find that in the end, because that might also be, I guess, revealing in terms of what kinds of intervention types are not effective at changing intended outcomes.
Yeah, so we did look at all the different outcomes, whether it was our primary outcomes or their primary outcomes. And so we did find some interventions that were not effective, and so in our realist review, we're going to figure out some explanations to why something works or doesn't work.
Great. Thanks, Monica.
I think next one to Quebec City. Any questions from Quebec City?
Yeah. Hi, Monica. This is Matthew Munir.
Hi. How are you?
Doing good. I want to congratulate you. This is a tremendous amount of work. and very, I liked how you really presented all the steps, so I want to congratulate you for that. My question has to do with how you broke down the components and then how you tied the results to those. So, and I think that I'm going to be really interested in when the realist review part of it comes in, but I had a little bit of trouble understanding maybe the added value of the different components. So education was often something, a component that was seen across studies in a lot of the different studies, but then you had sometimes education with one component or another. Was it hard for you? Like, maybe you can talk about how you try to understand the added value of having different combinations of components for these interventions.
Yeah, so your question is a good one, because this is one of the things that we've been struggling with, is how can we possibly tease out the component that is responsible for the impact? And the problem is that we didn't have a lot of good, sorry, I'm getting a bit of feedback here. So we didn't have, because a lot of the studies had selective reporting or didn't report well enough in their outcomes. Sometimes it was difficult to figure out whether the impact is due to the education or is it due to another component. So we're still trying to tease that out, and we're hoping that the actual realist review will help us fill in some of those missing pieces.
Okay, thanks. Good luck.
Thank you.
I have a question from Ottawa.
So it's Dawn Stacy. Thank you, Monica. It was really helpful to see the breakdown. My question is that the studies had to have at least 2 or more comorbidities. And my question is, when you looked at the interventions, did you look at whether the interventions actually addressed 2 or more comorbidities, or was the intervention really about addressing one comorbidity?
Yeah, so we found that very few of the studies actually were developed, or the interventions were actually developed for those 2 diseases. Oftentimes, particularly the ones that were self-management strategies, they would just take a particular strategy that they have tested on previous populations and then now tested on people with multi-morbidity. There was only, I think, 2 or 3 studies that were actually described their intervention in terms of their purpose was to develop this intervention for that particular disease cluster.
And then Briere Research Institute, also in Ottawa.
No questions here, thanks.
And McMaster?
Hi, it's Brian Haynes, Monica. Thanks very much for your presentation. I think you covered a big bunch of territory. I have a few questions. I'll focus on a couple of them and see where I get with them. First of all, education is a rather broad term. Did you have any particular definition of education, or do you actually mean instruction? Some people would include behavioral strategies as part of an educational strategy, for example.
Yeah, so we defined our components according to the EPOC criteria, and then we did a hybrid sort of criteria based on the old criteria and the new, and we included anything under an education that had to do with one-on-one meetings with, for example, a practice nurse talking with a patient at the hospital, to workshops, to all these different types of educational strategies that are one-on-one, different settings. It could be paper-based, it could be in any format, electronic, paper-based, in-person. So it's a wide spectrum, but we do have a code book of definitions for each of those elements that we're going to include in our publications.
Okay, thank you. I was trying to follow, you presented a pile of data, so I'm not sure I got this right. But I was looking for effects on patient-important outcomes as opposed to questionnaires, self-reports, surrogates like A1C and so on. If you looked at the results for patient-important outcomes, first, I think there's hardly any studies that measured them. And second, there wasn't any study that showed an effect on a patient-important outcome. Is that a fair assessment?
It is, Brian, and that was one of the things that we're going to include in our write-up, that it's a very large gap in the literature, is that even though the interventions are targeting patients, there's very little on their particular outcomes other than quality of life. And there was a couple of studies that looked at knowledge uptake. There were only 2 studies that looked at knowledge uptake. So that's a huge gap.
And I'll just send off with this last one. Were there any studies that looked at the durability of effects, particularly after they stopped the intervention? And also, were there any that looked at adverse effects of interventions?
So none of the studies looked at, like if you're talking about sustainability of the intervention. Sorry, what was the last piece that you wanted to ask about?
Looking for any adverse effects of intervention. The background here is that we provided instructional program for people with high blood pressure and found that it actually affected long-term promotions and income. People took more time off work and they didn't get promoted and so on.
And we didn't find any outcomes. None of the studies reported on any outcomes related to adverse effects.
Right, thank you.
And Winnipeg. Not hearing any questions from Winnipeg, we'll go to Edmonton.
Thank you for the presentations. We don't have questions.
Okay. And Gorge Road Hospital Island Health. Oh, that is. So there are no questions. And finally, here at St. Michael's. Are there any questions from the audience?
A comment and a question. You were a very clear speaker and with great fluency, so that's very positive.
Thank you.
Why can't you create a standard effect size instead of presenting p-values, but p-value reflective standard effect sizes would be much more interesting for us as readers. So that's a comment. Maybe it's a question and a comment. But we would like that. The p-values are difficult to swallow. And then in the earliest of your slides, are you able to go back to your earliest slide? When you talk about your objective at the very beginning, you're sort of talking about integrated KT. I'm sorry to pull you back to the top of your slide deck. Why is this framed with knowledge translation? Like these interventions, this isn't knowledge translation that you're really talking about as the intervention. They're different sort of personalized, team-based approaches to the modification of care in people with 2 or more chronic conditions. But I don't see with your terminology the strategy. I think what you're doing, looking at this as sort of a KT strategy, and I don't want to pull it apart, but I'm not sure those are KT strategies. There's sort of these other really mixed efforts. So I'm just sort of challenging your very early use of CEM KT strategies.
Okay, great. So I'm gonna I'll just repeat your question for those of who are online. So the first question was around the potential of standardizing the effect size of our findings rather than using p-values. So this, the results that we've just highlighted here represent really just a narrative organization of our findings. So we're trying to find ways of pulling some of the results in a meta-analysis. So we've begun that process, and there's at least 2 or 3 comparisons that we know we can pool in a meta-analysis, and that will give us a better point estimate of what's going on. Unfortunately, one of the problems is that there's very poor reporting in studies, so we may have to go back to the authors to get some data to be able to do that. So that's another challenge that we're facing. The second question was, why did we call our strategies KT strategies when they're mostly related to collaborative care and quality improvement? So we were looking for, the way we define knowledge translation tools is any kind of strategy that really facilitate the uptake of knowledge about chronic disease management. And that is unfortunately also poorly defined in the literature. And so we were very broad in our definition of what we were looking for in terms of the interventions, because there's been different language used across the literature for these. So that was the reason for that.
Thank you so much for your presentation. My question, I was wondering if you're applying an equity lens to studies that you looked at, and I know in the Cochrane group there's sort of some really excellent methods that developed to. The related question is whether issues that may come out when you're doing your research around social determinants and level of income or education level, or whether that access is on.
Yeah, so those are excellent questions. So I'm just going to repeat the question for those of you online. The question was whether we applied any equity lens to the studies that we've considered, and whether we've looked at some issues related to social determinants of health. And I think these are excellent questions and very important questions. And absolutely, our realist review is really designed to address some of those nuances and to make sure that we do look at those. And those have come up in our studies as things that are important to consider. And we will supplement what we found in terms of our quantitative data with some of these other issues that have come up that are discussed in a lot of the studies. We're looking at a lot of qualitative studies around some of these interventions that will address those.
The question in the back.
Thanks, Monica. That's a lot of work. You did a similar about 5 years ago looking at post-factor. And what we ended up doing was recalculating a lot of the rates because it was so important. So it's just sort of get a way of approaching and you guys thought about that at all? How people are reported, especially with the non-RCT studies?
So can you be a little bit more specific about what you mean by recalculating the outcome?
Because we found that the denominator, what we're looking at, the denominator is really variable. And so some studies would accept all comers as denominators for some that, patients have been test for example. And so it's always really hard to look at compare the outcomes of the study. So we ended up recalculating rates so that authors to get some data, all data, but it just helps us with sort of
Yeah, and that's an issue that we've come across as well in our work, is that a lot of the, so the question was, have we thought about recalculating our data given the variability of all the different denominators and event rates throughout the studies? And we've come across that issue with ours as well, because first of all, we had most continuous studies, but a nice blend of studies. And even within those, we found that some reported on mean differences, some only reported on baseline and follow-up values. So we are considering right now contacting authors to get more information so that we are able to do some more summary statistics on and to maybe standardize the means a little bit more to give more meaningful quantitative results.
Time for one more question. I don't know. Thank you. One more question? Go ahead.
Oh, I was just wondering, how do you deal with variable?
Oh, sure.
But how do you deal with variable times? A lot of
So the question is, how did we deal with the variable follow-up throughout our studies? And so again, this goes back to the methodological heterogeneity that we're looking at across the study. So we looked at the 3 types of heterogeneity, and that's one of them. And so we actually did not find that our studies were as heterogeneous across follow-up. There is some differences, but it's not as variable as we expected. And so basically you would consider those factors into consideration when considering to pool a certain set of studies and to describe those in your results when you do use them in a meta-analysis.
Please join me in thanking Monika for an excellent talk and very invigorating. I am asked to remind everybody on the web to complete their evaluation forms, and if you have an evaluation form on paper, please complete it here. Thank you very much.